a.m. in the morning and you're drenched in sweat, yet you feel oddly cold, wrapped up in blankets. And you don't want to eat and you don't want to drink because swallowing feels like razor blades. And you can't stop coughing enough to get any semblance of sleep. Your muscles are on fire, and every time you try and stand up, you have to try not to fall over. It's been 3 days, you tell yourself. Surely things should start getting better. And so you go and seek help. Perhaps you're lucky enough to be able to see your GP, who's usually booked out weeks in advance, or the urgent care centre. But they both tell you the same thing. You're too sick. Go to the hospital. And so you head down to the hospital, and the front door, the emergency department, where the security guard greets you and ushers you in to the triage area. And you're seen by one of our expert triage nurses who, within 2 slick minutes, can tell you how sick you are based on a category of 1 being the sickest to 5 being the least. Now, you're not dead and you're not dying, so they make you a category 3 and you wait. The doctor will see you eventually. Now, that's where I come in. I'm an emergency doctor. Now, the typical response that I get to that is, and what sort of doctor do you want to be? You see, we know that cardiologists look after the heart, neurologists, the brain, paediatricians, children, and even surgeons who cut things out and put things back together. But unlike cardiology, which has been around for over 400 years, emergency medicine in Australia has only been around for the last 40. And what do? Well, we're the front door to the hospital. We see patients, we treat their symptoms, we diagnose, we resuscitate, and we act as the safety net for the healthcare system. And too often do we bear the burden of an under-resourced system too. We work as a team of doctors and nurses, of pharmacists and physiotherapists, of clerks and cleaners, of orderlies and aides, and we work together to look after you. And we have the absolute privilege of looking after you at your most vulnerable. You see, I often hear patients tell me, "Doc, I'm sorry, I didn't plan on coming here today, but I had nowhere else to go." And as a team, we save your life. And when we've exhausted the limits of modern medicine, we support dying with dignity. But that's not you. Not yet. You've been waiting 4 hours now in those uncomfortable plastic chairs, and you're sharing that waiting room with kids that are crying or fallen over, patients with deterioration in their mental health, making a lot of environmental noise and scaring our elderly who are confused or perhaps just not coping at home with their illness. And still you wait. The doctor will see you eventually. Someone walks in to the ED, they've twisted their ankle, and they've been waiting 30 minutes and they're called in before you. How's that fair, you tell yourself? Well, you see, about a decade ago, what happened was as ED presentations increased, what we found was that if we only saw patients based on how sick they were, we would never see our Cat 4 or Cat 5 patients. Your fractures would never get plastered. Your wounds would never get stitched. Your kids who had food poisoning would never get the rehydration that they needed. What we needed to do was split our resources. And so what EDs did internationally was they created 2 areas, an acute area for the sicker patients who are resource intensive and often came into hospital, and a fast track area where patients did not need as much work, did not need as many resources, and often went home. It is these patients that were your GP type patients or urgent care type patients. And because they went home, they do not contribute to ED overcrowding. GP type patients do not contribute to ED overcrowding. Urgent care centres do not alleviate ED overcrowding. The patient with the twisted ankle hobbles home about an hour later because they went through fast track. And you hear those magical words, "The doctor will see you now." And as you're brought into a bed in the ED, 6 hours after you've presented, you're looked after by the doctor and the nurse, and you're diagnosed. The GP and the urgent care centre doctors were right. You're very sick. You have sepsis. Your body's overwhelming response to an infection that's causing your vital organs to shut down. You need antibiotics and you need to come into hospital to make sure that you're getting better. So we refer you to the inpatient teams for your ongoing care, and we book you a bed up on the ward, out of the chaos. You'll be moved out of the ED, out of the chaos, eventually. Now you may be thinking to yourself, that's all right, I'm in a bed, I've been seen by a doctor, I'm being looked after by a nurse, I've got my antibiotics going, I'm safe, right? Well, the reality is that the longer that you stay in the ED, the higher your risk is of dying unnecessarily. The longer that you stay in the ED, the higher your risk of dying unnecessarily. Research has shown that up to 1 in 80 patients who have to languish in the ED for more than 8 hours will die unnecessarily. In fact, the biggest risk to patient safety and the biggest threat to the security of our healthcare systems is the exponential growth of ED overcrowding. You see, while you're in this bed in the ED waiting for a bed upstairs, there are 4, 5, 6 more patients waiting in the waiting room for your bed. The doctor will see them eventually. And our ambulance colleagues suffer the same fate. They have patients on the stretcher waiting for a bed in the ED. Will that patient at home waiting for an ambulance? The paramedics will see them eventually. And this issue is compounded because the ED has only so much quality care that it can offer. And with more and more patients, that quality goes thinner and thinner until it no longer resembles quality. The longer that you stay in the ED, the higher your risk of dying unnecessarily. Now, the first step to finding a solution is to acknowledge that there is one, and hopefully we've done that today. Healthcare is a complex beast, and solutions can often be misinterpreted and myths can form, and I'd want to go over some of them today. And the first one is, well, why don't we just build bigger EDs? Now, that makes sense because that would help with the quality. We wouldn't have to spread it so thin. But the reality is that as an emergency medicine specialty, we are very good at the first few hours of your arrival to the ED. But after that, there are better people and better places to look after you, to care for you. So then why don't we make bigger hospitals? Now that might work in a world where we had an infinite budget, an infinite workforce, and infinite space to build on. But in our finite world, the hospital only makes up a small part of the larger healthcare system, and we need to invest wisely. And if we only invest in hospitals, we're neglecting the rest of the system. And thirdly, why don't we just get rid of all those patients that don't have to be in the ED, those low acuity patients? Now, as we've said before, those patients don't actually contribute to ED overcrowding. They only offer a distraction for the real solutions. And finally, why don't we just work harder in the ED? And you may laugh, but that's been the longest standing solution that's been going around, and it's only recently that we've acknowledged that actually the solutions are outside of the ED. You see, if you want to see how safe your health service is, all you have to have a look at is how many times that safety net has to be used. The ED is the safety net for the healthcare system, and it is at breaking point all around the world. So what are some of the real solutions then? Well, researchers have had a look at that traffic jam of patients in the ED. They've tried to follow it all the way back to where the big bottlenecks and barriers are. And what they've found is that one of the overwhelming causes of ED overcrowding is hospital exit block. Now, what do I mean by this? You're sick, you go to the ED, you get admitted. Hopefully you get better. And you get to a point where you no longer need that hospital bed and you can make your recovery at home. Now, for a lot of patients that are stuck in the hospital, they can't make that leap. They need a little bit of extra support so that they can be discharged from the hospital. They need things like rehabilitation beds, respite beds, palliative care beds, hospital in the home services, virtual care services, acute GP, nurse practitioner, pharmacy, OT, physio services. We don't have enough of that at the moment, which is why our patients are stuck in hospital. But you guys have a bigger role to play, as the public in how we alleviate ED overcrowding and unnecessary deaths. Life expectancy is often used as a yardstick for how healthy we are. And we are living longer than we ever have before. But the rate of how much longer we're living is starting to slow down, and that signals the fact that actually we're becoming more unhealthy. And as we become more unhealthy, that means more sick patients, more patients in the ED, and more patients on the ward, and more exit block, and a system that quickly becomes overwhelmed. And what we find then is similar to what we saw with COVID, with a system overwhelmed. And I don't have to tell you what happened there. So what do we have to do? Well, we have to think big. We have to put healthy communities back on the agenda urgently. And we have to think about what are the causes of a healthy community, the social determinants of health. These are the non-medical building blocks that determine if the health of our communities succeeds or fails. Things like cost of living, food security, housing, education, the climate. These all determine if the health of our communities succeeds or fails. And we need to do this urgently so that if your great-great-grandchildren or loved ones ever need the ED, the doctor will see them soon. Thank you.